This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care to me means I am practicing the best medicine of my career by far. Direct primary care has allowed me to practice lifestyle medicine for every single patient I come in contact with. So that's lifestyle medicine for all. And direct primary care is the true patient-centered medicine, where others are patient-centered in name only or because of some acronym. DPC is truly patient-centered, direct care to our patients. We work for them. I am Dr. Amy Mechley of Integrated Family Care, and this is my DPC story.
Dr. Amy Mechley loves being a physician. She attended St. Louis University for her undergraduate years and then earned her MD from the University of Cincinnati College of Medicine. She then went on to the University of Utah Family Practice Residency at McKay Hospital. After residency, she completed advanced clinical training in cardiac wellness at Harvard's Henry Benson Institute in Mind-Body Medicine at Massachusetts General Hospital. She has been practicing medicine in Cincinnati, her hometown, since 1998. She married a native Cincinnatian, and they are the proud parents of 3 fantastic children. Dr. Mechley takes an innovative approach to some of the most challenging concerns in healthcare today. She is a recognized physician executive in primary care, which gained her national recognition. Dr. Mechley has worked with all the regional Cincinnati healthcare systems. At the beginning of her 20-plus year career, she began a relationship with the University of Cincinnati, the Christ Hospital Family Medicine Residency, and today continues to guide and teach the residents, our future primary care physicians. Dr. Mechley feels strongly that primary care physicians need to be independent in order to serve as true patient advocates. Primary care doctors can work fully in the best interest of their patients, fostering a deep, caring relationship to help improve health and promote wellness. She became the first doctor in the region to be board certified in lifestyle medicine, which focuses on a partnership with the patient to improve their health. This is done by understanding the root cause of the issue and not just treating the symptoms. She has been awarded many teaching awards, has been on the local Best Doctors list yearly since 2010, and has also been named as a Best Doctor in America. Her favorite award, though, is still a hug from her patients. Dr. Mechley and her DPC partner, Dr. Glass, have been crossing paths through the years as they both move to fully embrace a more holistic approach to medicine. Their synergy and aligned missions brought them together to open integrated family care in 2017. The practice embodies all the learnings from many years of work as a caring doctor, along with an executive understanding of the business of medicine. She feels this practice is a culmination of her calling as a healer. Welcome to the podcast, Dr. Mechley.
Thank you, Mariel. It is always good to talk with you. Always.
Your opening statement really speaks to all of us in the direct primary care movement, in that if we don't realize it when we're learning about DPC, we really truly understand that this is true patient-centered medicine when we have our first DPC patient. So can you please share with us, as we open here, the story of integrated family care and how you and your partner in DPC, Dr. Glass, became not only outstanding family physicians doing family medicine, but under the direct primary care model?
Oh, I love it. Yes, I'll be happy to share that. Happy to talk about my journey. And hopefully it pertains to a lot of other people's journey and gives them the courage to take that step. So I would say my journey started before 2015, but 2015 is when things got real. And I was working in a large healthcare system in Cincinnati, Ohio. I was the medical director working under CMMI, which is the Centers for Medicare and Medicaid Innovation, one of their innovation projects called CPCI. I know a lot of jumbled terms there, but that was an advanced primary care movement or advanced primary care model that they were testing out. And it was essentially a progression from maybe a patient-centered medical home. We know that concept first started maybe about 15, 16 years ago, saying, gosh, we really do need to be patient-centered. We're in my mind, losing our way. And that was a very much a nod to that. And that turned out, in my opinion, to be much more of an administrative move than it was true outcomes that we saw from that. The ideals were good, but how it was executed. And we see that all the time, especially when a lot of these models come from payers. And CMMI is essentially a payer. And I'll actually stop right there because you'll see my background is also in a lot of healthcare reform. I still use the term payers, but if we think about it, and I think this is critical to understand in the large macroeconomics of healthcare, payers are the people that are actually paying for healthcare. And those are you, me, the individual, because we pay taxes. And we also pay directly for healthcare, and then the employers. Those are the only two bodies in the United States that really pay for healthcare. Even though we consider the BUCAs and the government payers, it's transactional. They're just passing things through. So I was in that world. I was a medical director for CPCI, and I kept thinking, this has got to be more simpler than we're making it. This is just too cumbersome. There are so many different additional needs that are being placed on the physicians, on the administration, and they're basically saying, we want you to perform, and then we'll pay you later. And we're like, we can't do that. That's not primary care. We don't have this large margin like some of the specialists do to hire 3 nurses and then see how our outcomes go. So we really were pushing for some direct monies or some early monies, investment monies that we would then have to true up in the end. And that's where CPCI kind of came from. So when I was looking at a lot of these different models, I was looking at something called micro practices, and those have been around for a while. And Garrison Bliss, again, we always consider him one of our fathers of DPC, and he practiced in a format that, again, became what I think is the current DPC model. So I was investigating some of these, and I thought, this makes a ton of sense. The thing that I think makes the most sense is to take third-party payment out of primary care. Primary care is not expensive. It is foundational. It is budgetable. It's predictable, and everybody needs it. And we know from the research that everybody's healthier when they have routine and regular care by an individual, by a physician. So I was like, okay, this to me, and it's the whole adage that we use now in DPC. Why would you use your car insurance to pay for gasoline? Why would you use, that was kind of that click, like ding, 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 because we're already caught up in this thought that you have to use medical insurance. And you'll see it, our patients run around like, I have a card. Don't I get that for free? Or I have a card. And we're like, well, that's unfortunately not how this insurance thing works, just because you have a card, especially as a transition from the 1970s to the 80s. And that has all had some significant impacts on what that means to have insurance. So I was like, this has got to be a lot simpler. And obviously there was some burnout, there was frustration with large healthcare economics, and then seeing the suffering of my colleagues. I'm the medical director. I'm supposed to be standing up there with my pom-poms and rah-rah going, come on, primary care, we got this. And it was crushing me in a lot of ways, my heart, because I'm seeing these great doctors doing things that aren't consistent with where they thought they should be at all. So I had considered making a change and went to an early DPC conference. I think it was 2013, 2014. I honestly can't remember which one. Came back and was like, this is great. So I spent the next probably 2 years putting together a business model. So I don't mind risk, but my husband will laugh at that because he doesn't think I like risk a lot, but I like a calculated risk. I like to say, okay. So then I thought, if I'm going to ask a partner, which was always my plan from the beginning, and we can talk about that because there's different ways of doing this. I want to make sure I de-risk it as much as I can if I'm going to bring somebody else in because I'm willing to understand what I'm taking out as a risk. So I created this business plan. And we'll talk a little bit, if you want to, about my design thinking background, because in the immediate time, I went and got a certificate in design thinking, which blew my mind, did this thing called business model canvas, really took the DPC concept and pushed it out on this big, I had a white wall that was about 8 foot by 4 foot. And the typical sticky notes, everything else. And you look at who all the stakeholders are and what is your value proposition for those stakeholders. And I took it back to one of my mentors at Xavier University for design thinking. He's like, okay, when you have a business model that meets the needs of all your stakeholders, he goes, I rarely see that. And I'm like, yes. I'm like, okay, this is not going to be easy, but it's pretty simple. And that's what I kept coming, it's not easy, but it's simple. So long story again. And so that's where I again attacked it from that perspective. Then I was all excited. Dr. Glass, Eleanor Glass, we had met because I was on faculty. I taught at the University of Cincinnati for a very long time in my career. I was on faculty. She was one of my residents. She then joined faculty. So we were co-faculty members at the time. And I was recognizing in her burnout. And she was getting crispy. And she is an amazing person, an amazing physician. So I remember when I went to her one day, I'm like, can we have lunch? I said, I have this idea. And I started talking to her about it. And she was kind of like, and she's brilliant. She's very headstrong. And I could tell she was like struggling with it. And I said, I know. I said, why don't you go to one of these conferences, see what you think? She went to a conference, came back on fire, and then the rest is history. So we opened in 2017. I came from originally a faculty position, and I did some consulting in between to try to, because I didn't have a full practice at the time. I had last saw my own patient panel probably 4 years prior to that, because I came on full time back to be medical director and do these other administrative things. So my point is, I didn't have a patient panel at the time. I was seeing the patients with the residents, but she did. So we started with 50 patients between the two of us, and they were her patients. They weren't even my patients. And that's how we started. And I can tell you now, it's been 5 years. We've had a wait list for 2+ years, and we are, having a great time.
Absolutely incredible. And I love that you highlighted your experience at Xavier and your experience with the design thinking and the business canvas, because, when I had done my research about DPC, I did not know that the business canvas existed until I took a SCORE class. And so I want to ask if you can share a little bit about what is design thinking, what is the business canvas when you have it as your architecture to build your clinic off of it, and did your original business model look like what it does today?
Yeah, those are great questions. So the business model canvas is something out of, and actually I look over here, I've got a bookshelf to the left, and it is, I had a lot of these like lean startup change, a lot of these business books, Switch, that I was like, just this whole idea of how do you innovate? And again, you have to be just not different, but you have to be different and better. And what's that value proposition? It gave me a lot of language to start understanding some of these concepts, because I didn't take a business course, zippo, all the way through college. I was science all the way. So this whole idea of economics and understanding these models started to intrigue me, because I thought, if we have to find an answer to healthcare, we need to do it with understanding all the stakeholders, all the people that are involved, and how to make that change. And what are the needs of all those different people? And if we can meet those needs, whether they're our patients or the payers, like we talked about, et cetera. So the business model canvas, and I keep coming, and I apologize, this might not be correct, but Stargazer is, I can't remember if they were the founded, because I would love to give credit, but there's an actual process called a business model canvas, and then the value proposition. And I'm a visual person. So it breaks it down into these 8 boxes, these stakeholders, and you have to think about what are the pains or the gains of each of these people that are involved in your ecosystem. So that was kind of the model that I learned in design thinking. But design thinking itself, that was just a tool that I had. Design thinking, the way I describe it, it's human-centered design. So you literally have to keep this human in the middle of your design. So you're not designing a product, you're not designing a solution, you're designing for humans. And the thing that it made me do, which made me crazy at the time, is I could not think like a doctor anymore. It made you stop thinking like, I got this, like, oh, I've taken care of diabetics. I understand that. You have to really stay, I don't know anything about this human being. And then you have to discover what you need to discover about the person you are designing for. And that's where we kind of talked about personas, and you would understand different personas and different needs. And it was so frustrating because you feel like, I've been training for this, I'm doing this, this is what I do for a living. And, this is why we keep coming up with the same stuff. You really have to go back and say, what am I doing? So to answer your question, design thinking to me is that very strict human-centered design model. And that, like, a lot of the key phrases are how might I, how might we, and you're just doing there's multiple rotations where you go through design thinking and then you question what you did and you have to go back and then you have to, so it takes a lot of time in the beginning, but once you start doing it, it gets you to the places you want to be quicker, if that makes sense. So.
Absolutely. So with that said, you and Dr. Glass have shared before, I believe this is the 2019 DPC Summit in Chicago. The link to that video will be in your accompanying blog. So definitely go check it out. But you guys share how even during your week, you continue to work on that avatar and making sure that your value proposition is continually, appealing to your population. And clearly it is, with your wait list being as it is. So can you share a little bit about what that looks like and how you're able to build that time into your daily routine, even though you guys are a full practice?
Sure. Yeah. And I give a lot of credit to Eleanor, Dr. Glass, my partner. Again, I have a huge amount of respect for her as a person, but her mind, she just has this beautiful intellectual mind, and she's extremely compassionate. I mean, she's like this, wonderful person and package from a physician. But so her and I were working on different things when we were in the residency program with what's called TWI, or training within industry. And it has to do with what was before the lean model. So have you heard of the Toyota model, the lean model? That really took off. I think it was probably the 1990s, maybe early 2000s. I can't remember. But what that was based on is something called TWI, which is training within industry. And those were concepts that really helped keep businesses focused, organized, but more specifically, how to train people coming on so you got a consistent standardization. So it was along those lines. So from that, she's got these great concepts about how to do that and maintain a workflow that's a continuous quality improvement workflow. So we both had that language, and she continues to work in that area, in that field. She was actually just at a TWI conference. She's like, I think probably one of the first physicians to be at a TWI conference and speaking. So we've come up with ways of continuing to embed that, because you can get stale pretty quickly or think what everybody around you is needing from you. So just some of the things we do, we do the huddles, we're looking at those on a regular daily basis. We do a Tuesday meeting with all of our staff. And what we have, one of the key components, and again, we've grown over this last 5 years, so I'll just talk about where we are. And if there's anything I can remember for people just starting, like, hey, this was important. But we had an area in our office, and we do definitely have the kind of the do act plan. Do we need to be looking at different things? And like one of our modules is safety. Are we doing well with safety? Just because we decided here's our vision statement, here's our priorities. So let's make sure we're putting these out there. So we used to huddle in front of that wall. And then when we went virtual from COVID, it was not virtual, but some of our staff members weren't right there on site, but we still have that kind of mantra in our mind. And then what we have is this, those big, huge white Post-it wall notes. So we keep one of those in our back room, and we have 1,000 square feet. So our back room is like a beautiful converted closet. And anybody at any time, we have markers right there. You just scratch a note. Not a complete sentence, not anything like, hey, I just thought of something. Why don't we do it this way? Or why am I doing this? Or I'm a little frustrated here. So it's in the midst of your workflow, you're just scratching what you want up there. So it's really nice that you don't have to say, oh, let me put together an email to the office manager to talk to her about this, this, and this. And it's everybody, and we have a lean staff. There's not a lot of people there, but everybody can do it. And then on our Tuesday meetings, we just take it, like I have it behind me or Eleanor has it behind her. And we're like, okay, who wrote this? What did you mean? Oh my gosh, what a great idea. Okay, who's going to take that on? Do we need to? And then if it's too much to discuss there, we have something called, it's from a book called Traction, which we really like as one of our latest business books that we've read. And again, Eleanor, in the book Traction, we talk about rocks. So every 90 days, we set no more than 7 rocks. And these are the things that we feel like we have to move, the rocks that have to be moved. And then we assign those rocks, and that's between Eleanor and I. And then everything below that should be pushing towards that rock. So we don't get distracted by the shiny penny, so it's resource allocation and thought. And those all have to point up to our vision. So once a year, we have a retreat. We relook at our vision. Is this correct? Then we do this quarterly rock resetting. And then we have 90 days to work those rocks. And it's okay if you didn't finish that rock. We just then say, is it important enough to continue to go for the next 90 days? So it's just it sounds a little complex, but it's not. It's a really good way of keeping things moving and quick and efficient and making sure we're all yoked and rowing in the same direction. And we're getting feedback, hopefully from a 360 to make sure that we're doing that. So maybe more detail than you needed, but that's kind of how we've embedded that in a day-to-day regular quality improvement type of thing, just for our small office.
We can easily, as DPC doctors, because we're doing everything and wearing all the hats, sometimes it's very easy to get into the weeds. So I really love that. And as a result, you guys have also continually worked on your culture. And I think that that's a big thing that a lot of people have, questions about. How do you maintain culture? How do you bring somebody on and have them understand what you're doing, even though they're not the creator of the clinic? So I think those are really valuable tips.
And that's actually one of our vision. So we have those, we have no more than 7 because you can't do more than 7. We decide. So sometimes there's 5, et cetera. But one is usually around culture. I love how you picked up on that, or you pointed that out, because I agree. We can look at finances. We can look at marketing. We can look at the stuff that maybe keeps us up at night. But if you don't have culture and you don't foster that, it's going to really start to erode your day to day. And then it'll come out in all different ways. So I think I'm spot on.
Awesome. Now, I want to go back to the root of your guys' culture, because one of the things that you mentioned was that you were intentionally wanting to open DPC with a partner. And so you talked a little bit about Dr. Glass and her personality and her abilities as a physician and as a person, and her complementary skills that go along with yours. But in terms of, if a person is listening and they're thinking about, who would be the person to go into business with me? What are some tips you would say to them when they're thinking about who to choose to open DPC with?
Yeah, that's a great question. I think the first thing, and this comes from like some Stephen Covey work, is know yourself. Be really honest with yourself. Know, why are you doing this? And then what is your personal skill set? Like, I like the business end, and I would not have said that 15 years ago, but I don't mind doing the numbers. I don't mind looking at contracts. I don't mind. And I think it's, to me, it's like a challenge, or not a game, but it's like one of Eleanor's. So we were funny when we first opened, it was literally the 2 of us and an office manager. It was 3 people. And we were coming up with titles. I'm like, okay, you're chief this, I'm chief that, just for the fun of it, because we're the owners. So one of her titles was chief label officer, because she got a label maker in her hand and she was off. So I'm like, fabulous. That is not intrinsic me. That is not me. So I think coming to this and saying, okay, know what your why is and make sure your whys are connected. Like I said, Eleanor uses a lot, we're yoked. We are definitely yoked, and we want to make sure that doesn't mean that we have to be in step with everything. And we respectfully disagree plenty. So good communicator, I would say that's really important. Know that you're yoked. If somebody's saying, I want to make $2 million in the first year, and you're like, I really want to help people who can't afford to pay, you're not yoked. And it doesn't mean that you can't be financially successful by doing this, but just kind of hearing that, saying, here's my why, here's what I want to do. And then here's my skill set, here's what I love. I need somebody complementary to that, because in the beginning we were both doing everything because we wanted our fingers on everything because we were learning. And then about 6 months in, we're like, we need to divide and conquer. We need to separate this. You're obviously much better at this. I'm obviously much better at that. And for us, we were both really conscious about this 50-50 thing. So it was like, we wanted to be sure that we're not asking more of another person than we were giving in. And what's interesting as I talk, I said that probably the biggest thing is to look for somebody who you can communicate with. Because if you can't have critical conversations or speak your heart as well as your mind, it's going to be challenging. And then I'm 54 and it's fun. I love my life. But this is where a friend of mine who's a business person, and I'll be careful here, I'll make it G-rated. But I was talking to him once and I was doing some consulting work and he goes, Amy, I'm at the point in my life, I don't have to work with blank holes anymore. And it hit me and I was like, hey, that's really great. If you don't get along with somebody or you don't respect them, you don't have to do that. You don't have to work. So just being thoughtful about who you want to spend your time with and how they're going to influence you and you're going to influence them. And we should be building each other. So I think looking for those characteristics, qualities that you really respect.
Amazing. I want to go back now to your opening days, because once you guys decided that it was going to be the two of you, you were going to open, what were the first actionable steps that you guys made with that business canvas in place and with the goal of your ideal DPC on the future horizon?
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
It's funny because you think, oh gosh, I will remember this forever, but it was, 5 years ago and I'm thinking, where was I? What was I doing? I think that again, we just did a lot of planning. It's different now. We didn't have the resources that that everybody I think has now. I mean, AFP didn't even know what we were, there was, I think maybe 400 people at that conference or 300 people at the first DPC conference. And it was kind of like buy it or build it. There was no buy it. You had to build it, So I leaned in really hard. And this is advice I've given to a lot of people, lean in really hard on the people that are around you that you trust. So I had an accountant that I knew really well. I had a banker that I knew. I had somebody in the family, my husband's cousin who is in commercial real estate. Cause I was like, what do I look for in a lease? What are the things that I can trip up on? So I did a lot of self-education, and now again, it's lean on us, we're in a big, much bigger sharing community. So what I did probably about 3 years ago is I went back and wrote the business, what I actually have, I have it on my screen up here, but it's a direct primary care business outline. And I've shared this in a lot of my talks. And I actually ended up writing the skeleton for a 60-hour curriculum on how to start your own DPC. And it hit right when I think a lot of the people coming out with a lot of this stuff. So I realized, the world doesn't need another one of these, which is fine because I'm not great. I already have 2 businesses. I don't want a third, but I was like, if anybody's interested in this, here's a lot of the think stuff. And I give this out at when I talk about DPC because I broke it down, and I'm just going to kind of read it. I broke it down to 6 modules. And I have found over the years, and one of your questions was, has we changed that much? We really haven't, which I was ready to pivot. Like we had pivot kind of points in place. And it's been fun to look back and think we really haven't had to. And I think it's because we did a lot of due diligence. So that's why I try to give this as a, here are those 6 things, make sure you're thinking about these 6. And again, the first is the creating a sustainable business, choosing an organizational system. If you've got sheets of paper and 3 notebooks and 6 places on your computer keeping this, you're going to too many resources. So making sure you're organized. I put the business model canvas in there, have a financial analysis, but basically called a pro forma. So, and this is the one thing that people are kind of like, I think it's going to be right around 50 patients or so. I'm like, no. You can do this on paper and you will know when you're able to hire somebody new, when you're able to buy more toilet paper. I mean, like you can kind of predict these things with fixed costs and variable costs. So then looking at your capital assets, your financing. So that's kind of all in just creating a sustainable business. Setting your price, what are your revenue streams? What do you want to do? And then module 2 was you actually have to run your practice like a business. And so that was HR, accounting, real estate, compliance, that kind of stuff's under there. Module 3 is protecting what you build, and that has to do with contracting, legal, business legal, and then all the insurances. Because you think, okay, malpractice, but then you got business insurance and cyber insurance, breach insurance, stuff like that. So what's really necessary, what's not. Module 4 was technology, because again, one of our taglines, we don't use it as much anymore, but was early tagline is old-fashioned medicine on a high-tech platform. Because we're your doctor in the family, kind of, the doctor down the street, but we're leveraging all this tech so that the access is there and the simplicity is there. And I know that we've all been able to do that in most of our practices, especially with the newer EMRs that are coming out that are more designed for us. So again, under that module is EMR evaluation. I have a spreadsheet that I give people. Just here's all the 6 EMRs you want to look at. Here are the probably 12 things you want to make sure you have in an EMR. And then are you paying for extra for bells and whistles? Because do you really need that? What do you really need for your EMR? And I love that, because when I used to be the medical director at the health system, I'd have so many vendors come to me and they're like, oh, we're going to sell you this. I'm like, I need you. Here's my problem statement. Here's this thing. It's almost like a pitch for me personally. It's personalized medicine. Here's the problems I want you to solve. And they were like, well, no, we're solving this, this, and this. I'm like, we're going to try this again. Here are my issues, because I don't want you to sell me something that is a piece of software that does what you thought I needed to do. I want you to sell me something that you understand this situation. So it was out of that work that I kind of came up with those things. Interoperability, that's tech. 5 was get your practice noticed. So that's like website branding, marketing, logo design, social media. And it's fun because some people, this is natural to them. This is like, okay, this is the world they live in. So it's no big deal. For me, it was like, what is marketing? I mean, I know what's branding, I had to learn a lot of that. It was fun. And then the last thing was just filling your practice. So, making sure you're getting the kickoff, and I think we'll cover some of those if we, the ones that we want to highlight, like what has worked for us or what hasn't. But anyway, that was because you were like, where did you start? How to do it? I luckily had most of that and then went back and really organized it. But that was what I think we didn't have to pivot a whole lot, because we had thought through, we understood our market, and kind of had an idea of what to expect.
Even if somebody has read resources and whatnot on business, entrepreneurship, or direct primary care, just to hear those words again and to hear your highlights, it never hurts to hear and, think about things in a different light, or, in the context of this conversation. So I think that this is just super helpful to hear that. Now, when you mention marketing, I want to go there next, because you're in Cincinnati. You're not in Arnold, California, like I am. You are in a big city. And so when you guys were opening and you were keeping lean, but having this amazing, tagline of old-fashioned medicine on a high-tech platform, how were you going about filling your practice with a particular marketing strategy?
Yeah, I'll tell you a few that we did that didn't work, because I think it's important. And I'll tell you the things that I think worked now that, there's a little bit in the rearview mirror. So I literally remember, and this was Eleanor's idea, we printed out a 1-sheet thing. This is who we are. This is what we do. And I think we made 100 copies, and we literally walked the streets around our building. I mean, I think we figured out, like, there's a 5-mile radius. You go this way, I'll go this way. And we knocked on doors. I mean, it was, and then again, like you said, big city. This isn't like people are like, who are you? Why are you, at my accounting firm? I'm like, well, we're right down the street. We're a doctor's office. And they were just like, what are doctors doing here? We met a lot of people. I do not think we got one person from that directly. But I do believe people started hearing our name, and they started hearing what was going on. So again, I think that was good still. We're great neighbors. We're in this community called East Walnut Hills, which is right up, like we sit on top of the hill looking down into downtown Cincinnati. So we're really close to being urban. And it's a really wonderful, eclectic neighborhood. So again, getting involved in your neighborhood. And to us, that just really meant really going out and walking. And people are like, seriously, you did that? I'm like, oh yeah. So that was one. Another one, I think Instagram has been great for us. And again, we have to think, well, we're marketing locally. I don't need somebody in Indiana to know who we are per se, until the second business we can talk about in a second, which is our network. But for our practice, it was very local. I'm trying to think what else we did. I went to a bunch of HR benefits. I talked to a lot of benefits managers. I talked to a lot of brokers. Some of that was my consulting work before. So I kept pitching what we were doing a little bit as I was doing some healthcare spend consulting work for some benefit managers in town. talked to a lot of CVAs because you were thinking about who else is like-minded that might understand we're here to take better care of people. And oh, by the way, brilliant, we're saving money for people, especially when you combine it with my lifestyle medicine, which, we can hit on a little bit because that's just such a huge value proposition. So that's what we kind of did early on. I think what was really successful is our info sessions. So we started because we thought, most of the time in old-fashioned medicine, it wasn't you're necessarily going to a health system or a component. You were wanting to see a doctor. You wanted to see that personal doctor. And that was one of our things that we knew we could be valuable with. Like you are going to come to see Dr. Glass or Dr. Mechley because we don't share patients. We cover for each other, but we don't share patients because we really wanted that long-term relationship. So meet the doctor. So as Karen, our office manager, were getting calls and she had a great pitch down because we had to work on that for our first 6 months. Like, what does she say? How do you answer those questions? Like, why don't you take my insurance? And, just those similar questions that we would get. She got her sayings down that were really good. And then she'd say, well, would you like to come meet the doctors? And people are like, oh, well, yeah. And so instead of us doing the half an hour or the 10-minute, phone interview, we decided we'll do this. And so we were holding them, I want to say twice a month. I think at one point we did it once a week, but we backed off to twice a month. And we said, this is when you can come. They actually physically came to the office so they could see the space. We kept it really simple within an hour. We started on time. We ended on time. Because again, we were like, we're building our culture here. We each took little tidbits of these 5 things that we knew that people tended to have questions on after we introduced ourselves. And then we left the last half an hour open for just open-ended questions. Like, what questions do you guys have for us? And then we gave a tour that lasted about 2.5 minutes because it's 1,100 square feet. And again, we would kind of explain, this is why, this is your medical dollars. We want to make sure. One of my jokes always was, you'll never see a chandelier in my office because that's not going to make you feel better. It's not going to be helpful, but you're going to see a really nice autoclave because that's important, So I think, again, it was just them seeing us as people. And then that, I think, really struck a chord, and then word of mouth started within a year after that, then the Instagram. So for us, the word of mouth, the info sessions, and then the Instagram posts were, I think, the most that hit for us, the most valuable.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. And during the pandemic, you guys transitioned and pivoted so that you had these info sessions online. And one of those examples is actually on your blog. So if you haven't seen Dr. Mechley and Dr. Glass's info sessions, take a look at their example. But let me ask you there, when you guys had to pivot and go virtual, did it make an impact? Did you still see the same interest in the practice?
We continue to see growth. So one of the things we did, again, and this was, we were actually talking about this with my office manager yesterday. We were like, you know what, because it's after COVID, not after COVID, we're still in COVID, but, after the urgency of COVID, and we're sitting here now, so we looked at each other like, we're really proud of ourselves. Like we did good, and all of that. It was quite the challenge. So we already had telemedicine because we started with telemedicine 5 years ago. So that didn't change, but we had to message to our patients, you can still see us. We're still seeing patients in the office, but we're not doing well visits. Like we shut down well visits. We shut down the stuff. Like it's just for urgent, emergent, but the non-urgent, emergent, we can still do video calls. So yes, when the message from the rest of the healthcare community was like, you can't come in and we can't see you. And most of the healthcare systems around here didn't have telehealth because of the whole, well, insurance isn't paid for, so therefore we don't do it kind of issues. We actually ended up, I called the lawyer that we worked with, and I'm like, I need a quick contract that people can sign that if they're not my patients, I'm still going to see them on telehealth, but they don't have a long-term relationship with me, which is very different than our current DPC contract. And she was like, what? I go, there's so many people that are not being seen. Their choices are emergency room, urgent care, or nothing. And I'm like, we're fully set up on telehealth. So we ended up very quickly pivoting. And so we saw patients that were not our patients, just for a quick 15-minute. And most of them were, can you explain this COVID virus to me? Can you explain, what do I have to do to be careful? Or I have a cold, or there were sprains, ankles, and the typical stuff. And it was all virtual. And so then I would say, okay, if you're not my patient, we could bring you in, but you have to do a little bit of a different thing, or you're correct, you should go to urgent care for this. So it was our way in the community of keeping people out of urgent care and out of emergency rooms during that time period. And that worked really well. And then we were one of the first people to give COVID vaccines in our office because they weren't giving them to primary care. And I'm sure you've heard that before. That was a really big thing for DPCs. I mean, had already started doing vaccines. And so we were like, yeah, we've got everything. So it worked out. Again, those were two big shifts that I think were really important during that time period. So I think because of that, we continued to do a lot of word of mouth, and we continued to grow. Now we slowed a few things down so to make sure that we could cover the patients that we were caring for, but we continued to take new patients.
Incredible. And definitely a testament to how the value proposition, even during a pandemic, really doesn't change in your case, even for non-members, because they still understand the access to a physician.
Chronic disease is a global emergency. According to the World Health Organization, or WHO, 80% of heart disease, stroke, and type 2 diabetes, and 40% of cancer could be prevented, primarily with improvements to diet and lifestyle. If you're interested in evidence-based lifestyle change to address the root causes of chronic disease and restore health rather than the less effective approach of merely managing symptoms, it's time you heard about the American College of Lifestyle Medicine, or ACLM. ACLM focuses on training, certifying, and supporting clinicians to apply evidence-based, whole-person, prescriptive lifestyle change to treat and, when used intensively, often reverse chronic disease. Go to lifestylemedicine.org to learn more.
I want to go back to the fact that you guys are in Cincinnati and you guys have created Try DPC within your area. So can you share with the audience, what is Try DPC and how do you guys exponentially affect more people with your guys' collective value proposition within Try DPC?
Yeah, no, I would love to talk about it because this is something. When we started, probably in our second year, we were working with employers because we really understood, like we talked a little bit about the payers before, like where is the value proposition? Employers are getting much more savvy in their understanding their healthcare spend. So we love the niche of 5 employees, 3 employees, probably up to about no more than 500 employees. But with Eleanor and I just being the only 2 physicians, we were doing like hair salons and real estate companies, small businesses like that, who they were like, we don't have to give benefits to our patient, but we really want to. So those companies are pretty easy to work with. But then as we got into larger companies, we thought, first of all, they don't want to sell all their employees. By the way, you have to choose between Dr. Glass and Dr. Mechley because choice is really important, especially when it comes to primary care. And they had this, gosh, we need more geography. And we also need to be compliant with the rest of our, what we call an SPD or wraparound product. So I like I said, I did some consulting earlier in the healthcare economics field, but mainly in healthcare benefits, like where's your spend going? So I would look at a company spend and say, here's where you're maybe, you need to be thinking about your benefits changing because your spend is here. And here's a high value provider in the area because of their cost and quality, et cetera. So I had a little bit of a background in that. So I started talking to employers and I was like, there's an absolute need for us to be able to bring these companies in simply and with compliance, and then allow and facilitate their employees to go to any of the DPC doctors around. So we were able to coordinate. We started the company called Try DPC, and I did it with the McGillen MD practice, another practice here in Cincinnati. And we've had the company now for about 2 years, and we have multiple doctors. So there are affiliates, and it doesn't cost the doctor to become affiliate, but you do have to qualify, meaning we want high quality doctors who are going to say, yes, this is how I'm going to treat these patients, because we have to go to the employers and say, this is what you're purchasing. This is what you're buying for your primary care doctors. They're going to do well visits. They're going to do sick visits. So all of those things are very clearly laid out. And then it's a simple administration with a single contract with that employer. And then in the background, we do all the hard work. We all do all the disbursement of the employees. We make sure that everything's compliant. So we put a lot of work in this from a legal perspective, from a document perspective, from understanding the ERISA law and the DOL law, because there's a lot that goes into that. So again, we're making it simple for the employer to say, yes, I want this. I get the value proposition. So I take by 10 questions that I ask the employers, 10 financial questions, I can create a whole business pro forma. This is what it would look like if your company used DPC during this time period. And it's really important for the CFO to see that, because they're like, why? We call it penciling out. It has to pencil out. It has to look right financially on paper. Like, what am I getting for this? I'm making a change. How is this going to affect? Most employers, I love it, understand that they're getting better medical care. And some employers are like, I'd pay more for that. But what I usually can show them is, based upon what I know about your spend, you're actually going to spend less, and you're going to get better care through our DPC docs because they are doing relationship-based care. So it's awesome. So we do all that in the background for them. And then for the docs, we'll help them with vaccines. We kind of talked about that. We work with a little bit as an MSO somewhat, but, helping them procure things. But it's always like, what's valuable for us? We get together quarterly to talk and share information, but then we help infuse the stabilization to the practice of all these employee-based patients. And it's worked really well. And we can expand anywhere in the nation if we wanted to. Oh, I like staying local, but it is really nice that we kind of have this umbrella to help facilitate that, which is, again, getting this DPC model out to more people, more doctors, in a way that is simple and compliant.
Amazing. And like Garrison Bliss has famously said, people like him, the pioneers of DPC, have built this movement, and it's up to us to determine what happens with it. And so I think that doing things collectively, locally, so that everybody wins is awesome. So I want to ask there, when a physician or DPC practice is wanting to join Try DPC, what happens? Is there a fee to join? Is there a shared marketing fee? How do you guys work it so that everybody is involved in benefiting?
Yeah, ours is really simple, and it's designed really for the independent physicians, the physicians that own their own practice. So we're really not set up right now for somebody to come. It is for each individual practice, but you couldn't come and say, I want Try DPC to pay me a salary and I'm going to go open a DPC practice. What Try DPC helps are the physicians that are independently owned by themselves, by the physicians, and they want to get into the employer space. So to become an affiliate, we just have a protocol that you look at and you say, do you meet these qualities? We obviously do background checks, make sure they have a license to practice in the state, all those things like that. And then we ask questions, because we want people to be of a certain quality and make sure that they are going to follow through with taking good care of patients. So, do you have after hours coverage? What is your after hours coverage? What is your sign out if you do go on vacation, things like that. And we can help with that. But again, we want to make sure that we're really bringing together this community so it keeps that legitimacy and the respect of what we're doing. Because I think there was something called a DINO, which is DPC in name only. I love that you had said that earlier, when we were talking earlier. And there's a lot of, me too, we do that. Oh yeah, I do that. And I can call myself that. And I'm like, you're not doing primary care. How can you call yourself, a direct primary care? And what you're doing is cash-based medicine, which is okay. But it's not that encompassing thing that people are looking for when it comes to the true primary care. So we vet the affiliates, but there's no fee. We think that's really important. And they could be part of us and say, I just want to hang out and see what you guys are doing. That's perfectly fine. I mean, so there's not a big leap to come in. But then what they would be open for is, when I get more employers, can I then use or market your practice as available for these employers? And it's a win-win. It makes the employees want to come in more. The employers want to come in more because they see more doctors, so they have more choice. And it really helps the doctors to say, yes, I've got all these different streams of people coming in. So it's that same business model canvas. It's stakeholders that the value is there for both. And so it works really well. When I'm bringing on a pretty significant employer, they're going to come on in October is when they come on. It's been a 3-year discussion. There's a long relationship building that comes with a lot of the employers, because they're like, this is different, this is new. So I do a lot of that because I can really talk the talk with the broker and with the CFO and with the human resources person and the benefits design. So that, I think, is a value to help people feel trusted when that comes through. They know everything's been vetted. And so it's just been exciting to put that to work and to be able to do that and help, like you said, push things up the hill and keep things moving forward so we can scale it.
when an employer joins and has coverage of their employees through multiple direct primary care physicians in your area or wherever in the nation, how does it work when you're developing those pro formas? Do you incorporate the existing prices of the independent practices themselves, or is there a set fee per employee that is shared amongst the different DPC doctors?
Yeah, it's a great question. We decided to keep it because some of our foundational pieces are transparent and simple. So everything we do is transparent. So you really see this is the money coming in. This is what's happening. So we set the price, and then we make sure our doctors are okay with that price. Like, would you be okay taking care of a patient and getting this much money for it? Because then it's consistent. The employer knows what they're paying and what they're getting. The docs know what they're getting, and they're hopefully, are comfortable with that. And so again, it's very transparent. And then it really helps from a ERISA law, which you have to really understand benefits law. There's a lot of technicalities. You cannot offer different things to different people. You have to be very consistent and standardized in your offerings to benefits for employees. So it's very consistent as far as what is offered and at what price point.
Now, in terms of lifestyle medicine, it's so funny because you were mentioning how you guys took, this 5-mile radius, I'm going to go, and that 5-mile radius, you're going to go. And it's so lifestyle medicine of you to just do walking the pavement. So I want to ask now, can you share with us about how you got into lifestyle medicine and this is why one of the big reasons why I reached out to you to be on this podcast is how do you integrate it into your practice?
Yeah. Again, there's going to be so much fun to talk about because I obviously, this is kind of the heart and soul of why we practice the way we do. And DPC was the mechanism so that we could bring lifestyle medicine in, because lifestyle medicine is not currently supported very well in a fee-for-service environment. I always say we really took a wrong turn when we started paying doctors to do and not to think. And it became transactional. So we're going back to relationship-based medicine and lifestyle medicine. I mean, what it is, just for people who don't know, they're like, what the heck are you talking about? Because a lot of people are like, oh, that's an alternative medicine, et cetera. It's really evidence-based, scientifically sound interventions that prevent, treat, and potentially reverse disease. So it is, if you look at any of your JNC8, any of your endocrine guidelines for diabetes care, et cetera, the number one intervention is lifestyle treatment, lifestyle intervention. And people kind of glaze through that because they're going to the pharma. And you're like, no, there's a reason. There's a total evidence-based, scientifically sound reason that we need to pause and stop there. And then it becomes a yes and with any other interventions, pharmacological, surgical, et cetera. So we talk about the six pillars of lifestyle medicine, and it's nutrition, movement, sleep, stress, substance abuse, a connectedness, social interaction. Because we know these are those foundational pieces that if we are not putting resources to those in our own health and well-being, things are going to happen. And the way I like to describe it, so again, and I'm not sure how much visual that our readers are going to see, but if I'm holding up my palm of my hand and I'm saying, okay, here's the root cause of disease. Here's what's going on down here. On my fingers are these symptoms. So I've got high blood pressure, I've got muscle aches or joint pain, arthritis, et cetera. If I don't come down here and just figure out if somebody's not sleeping well, or if they're eating very poor nutrition, then these things are going to continue. But if we start to correct those, and again, the lifestyle medicine is I'm not telling you what to do. I am kind of helping you on this path, and you are choosing to do that, which is huge because again, it's patient-oriented goals, patient-focused. It works beautifully. And everybody's like, and that's the thing about, we'll talk about the conferences coming up, but we're literally going to be teaching family medicine doctors how to do this well and integrate it. So this is where I get super, super excited because it's not like you have to have this special so special. The whole idea is we want to infuse lifestyle medicine back into primary care because it is truly the medicine that we thought we were going to be practicing before we went to med school and before we went to residency and we got into this gerbil trap thing. So if you start taking away or starting to actually transition the diseases or the issues here, all of a sudden it's like bink, 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 and you still might have one thing that we need pharma for. So it's not saying not medicine. But again, you're saying, okay, but now I'm treating this, and the resiliency of the patient and the health of the patient is profoundly different than before. So it is absolutely foundational. And again, that's why I get so excited about it. And it's not sexy. It's not, a lot of people will ask me, like, there's a lot of alternative or a lot of different types of medicine out there. And there's a lot of noise, because I always talk about the noise to signal ratio. And this is the issue that I have with a lot of people with the wellness and all the other, diet fad of the month kind of thing. We can distract our patients horribly, and people can get distracted significantly with influencers or to people that are pseudo scientific or pseudo medical, et cetera. But the signal's there. And if you're spending time out here, you're not getting to the thing that's going to make you the healthiest. So we really try to clear that up and say, really, we want to focus on this. And it's not sexy. It's not like I have a secret nobody else has and you have to pay me to come get this secret. It's broccoli. It's broccoli is not sexy. It's apples. It's movement. It's thinking about what you're doing with your fingers, your feet, your hands, your voice, and being, thoughtful and intentional about that. And again, DPC is that business foundation that allows me to practice medicine that is the most pertinent and most valuable for my patients, because I work directly for my patients and I do it in a relationship based, so that once I get to know that patient, I can say, here's what I'm thinking. Here's how I'm going to take the time and talk to you about your sleep, as opposed to writing 3 prescriptions for you. And it absolutely proves itself statistically in improvement of health, which if you think about healthcare reform in the big picture, it is much less expensive to take care of a healthy person than it is somebody with disease. So, and then the ROI is huge. So I went off on a little tangent. I'm not sure if I actually answered your question.
You totally did. The second part of that is the integration into your actual practice. When a patient is coming in expecting, like to fill out the forms and to, get their vital signs and then get their 7-minute visit, and then they experience something completely different at your practice. How do you guys develop the workflows so that you're from the get-go, from the initial intake already, like you said, trickling in that lifestyle medicine and incorporating it into their care?
Yeah, I love this because it's so funny. We were talking about some things. I took notes, and this is how we know this is real. I haven't looked at my notes the whole time. I'm like, yep. It's just so fun and easy to talk to you, Marielle, because you really deeply understand these critical concepts in caring for patients. And obviously this is, why we're both excited about this lifestyle medicine stuff. So how we infuse it, and it's from the moment we have contact with our patients. So one of the things we decided to do is we do a 30-minute patient intake. And we've started doing it virtually because of COVID 2.5 years ago, and we're keeping that. So my brand new patients, I do a 30-minute video call with, and all I do is review their medical history, get everything that I've come in through various electronic means. And when you have them fill out, we do have them fill out that one form to say, can you tell us? But as you know, that's like 70% accurate, because people are like, oh, I forgot about that surgery. Oh, I didn't even think about that. I have asthma. Is that a disease? And I'm like, well, yeah, when they say, but what's your medical history? None. And all of a sudden you're like, okay. So that 30 minutes really helps me. And I tell patients, I said, for the next 20 minutes, I'm going to ask you questions about the information you gave me, because not only do I want to make sure I have the details so I can be a better doctor for you, I want to understand what that means to you and how important that is to you. And then based upon that, we're going to make a plan of what we want to do next. And it's really fun because most of the patients are just like, oh, and their shoulders go down because they're used to doing that. I'm going to fill out all these forms. Nobody's going to look at me in the eyes. They're going to glance at the forms and put them to the side. They're going to click on all this stuff. And then, I'm not even sure if I really got any questions answered. So that sets up this basis of relationship. And we get so much feedback. Like people are like, this was lovely. Thank you so much. And I'm like, well, this is really important for our medical care. So that, and inside of our medical history, there are questions about sleep, nutrition, and there are real specific ways about asking this. And that's why I want to, when we talk about lifestyle medicine, I want to make sure people get trained, because once you get trained, it will just flow. And it's not going to be like, oh my gosh, now I have to think about doing this. It becomes just a natural part of integration into how to ask these questions and how to get the answers that you need quickly. And that's motivational interviewing, when we really talk about how to help guide people through a discussion. So in the beginning, we get some of that going. And then based upon that, I say, here's what I want to do. And usually it's, I want to get labs, I want to do this, and I'll bring you in for a physical exam. But in the meantime, I might send you some information on things that were important. So if you told me you have sleep issues, I'm like, hey, I want you to read this, and then we're going to talk about it. So we're planting seeds to say, yes, these are things that you can start to consider to do, not that your doctor told you to do. And so we're just starting to plant seeds in different ways. And that's the nice thing about lifestyle medicine is you can come at it from a lot of different ways because we're all different. So if you're an engineer and I say, I want you to, so for movement goals, and I'm expecting you to go walk in the woods and look at the butterflies, you're going to be like, what? No, I want to get on a treadmill. I want to be on for 24 minutes and I want to have my heart rate at here, because you're an engineer. You're like an analytical. So I can approach somebody who maybe is a violinist for the symphony, and they have a larger creative side. And I'm going to say, I want you to get on a treadmill. And they're like, oh, I go, I don't, you're taking my joy away. So again, it's just understanding where people are and what they want to do. So it's working that way in the beginning. And then as they come in, we just do some small goal setting, or I talk to them. I just kind of came up with this thing called anchors, and you listen. And I really feel that people have 2 or 3 important anchors. And if they don't resource this, their lives just are not flowing very well. So some of those anchors could be exercise. Like when I get up and exercise 4 days a week, my life gets into order. Or when I'm able to food prep, I can do this. Or when I get my sleep, I can do this. When I pray in the morning, I feel like my life gets better. When I spend time with friends and family. So I'll listen for their struggles and their stress. And then I'll bring up this concept of anchors. And that has really hit with people. And they're like, yeah. So I said, we don't want to do too much at once, but let's really get these anchors going. And then you can build on that. So those are just kind of some little ways. And then I think about the lifestyle medicine vital signs. I always tell, if I get a temperature on somebody who's not sick, what a waste of resources. And people are like, well, you just take a temperature. I'm like, no, I would much rather have a finger stick possible lipid level, because I know that that's going to be a really important driver for lifestyle medicine, where you are with your health. Or I would much rather have the blood pressure is important, or what's your sleep log. So where we put our resources and what we do, again, being thoughtful, not just saying I'm in this medical model and I need to have these to check my boxes. Like, I don't care if I have a temperature on somebody who's coming in to talk for their well visit. I'm like, I don't really want that. Or pulse ox is interesting because that's become much more important in the last 2 years. But a lot of times you had points for getting all this stuff. And I was like, so the lifestyle medicine vital signs, I think, is important. And then having people follow up in different ways, saying, yes, you can follow up through asynchronous means by sending in a log. I can have you work with a health coach. I can have you work with community resources. These are the people that I really like, and I can recommend you working with them. So as physicians, we don't have to do it all at all, but we're the person there that might be the trusted resource to say, here's what I'm recognizing. Let's talk about this. How do you want to, what are your next steps? How do you want to handle that? What are your first things that make you feel better? So just kind of discovering those things. And then, with our telehealth too, it can be a quick 15-minute video visit. They don't have to leave work. They don't have to do it, but we're doing a check-in to say, hey, you set goals that you said you were going to add another vegetable per day, and that was important to you. But if I never follow up on it, then obviously it wasn't important to the two of us, and it wasn't an important plan. So creating that accountability and follow up in very simple ways. So those are just some quick examples of how we can infuse that. So you're not thinking, oh my gosh, I'm redoing my whole office setting. No, I'm allowing this to kind of come in. And it is so important. And the patients recognize it. They're like, you listen to me, you get me. Yes. Now I trust you. Now I'm going to keep listening to you about some other things that might be even bigger drivers that I'm not ready to deal with yet. Yeah.
And it's so relationship, patient-focused medicine, just like the core of what you were trying to do before you opened DPC and now in your DPC. Another resource that's highlighted in your blog accompanying this podcast is the unscripted podcast that you did with the medical students that you work with. And it was so, again, it's like, even though we know stuff, when we hear it again, it can joggle our emotions and our thoughts differently. But when I was listening to that podcast in particular, when you were mentioning having, your services as the core primary care physician, and then being able to have other, services or people in your, like you mentioned, coaches, et cetera, being able to support that care. It was really, thinking as a micro practitioner myself, it was really freeing to not have to carry all of that weight to be able to do everything, like do all of the coaching, all of the things that that make sense. But I was listening to the interview thinking like, oh my goodness, like that is how she is an extension of herself, similar to how we have extensions of ourselves as doctors through virtual assistants or office staff, et cetera. So I love that. And if you have the time, I definitely would encourage you to jump on that podcast. The medical students do an incredible job there. But Dr. Mechley, your words there really hit home for me, and especially in that podcast. And when you talk about empowering physicians to be able to not feel overwhelmed, but also to be able to take actionable steps to incorporate more lifestyle medicine into their practice. You mentioned the conference for ACLM coming up. So I want to ask, what are your go-to resources when you encourage people to look into additional resources to learn about lifestyle medicine and to take that next step?
Yeah, because it is. People get excited and then they get overwhelmed. They're like, oh, I can't do one more thing. But they're drawn to lifestyle medicine because they're like, this is what I want to be doing. This is this medicine that brings so much joy to, we talk about the DPC doctors are the happiest doctors around. It's kind of freaky. It's like, because we're just doing what we know we can do. But this lifestyle medicine, it's like, it brings you so much joy because you really see that connection with patients. You see patients intrinsically getting better on something that didn't have to go through a prior authorization from an insurance company. When somebody learns to meditate, when somebody learns to food prep, and they're like, oh my God, I mean, asparagus. I never thought I'd like asparagus. It's hysterical. Like, yeah, you don't have to go back to the insurance company and say, mother, may I? These are foundational, and then they pass on and on. So when people get excited about lifestyle medicine, one is the lifestyle medicine website. So it's literally the word lifestylemedicine.org. And that's the American College of Lifestyle Medicine. So that's the foundational educational society that I've been involved with for a long time. The people there are outstanding. If you want to go, like we go to DPC conferences, if you want to go somewhere and leave like you're floating on a cloud and you're like, oh my gosh, these are my people, and these people are doing amazing things and I can do it too. Because it's not just you look at people and go, wow, you're a star. It's the same thing. It's the same thing in DPC. It's like, tag your it. We're all part of this community. We're all adding to it. So that conference, that's the ACLM, the American College of Lifestyle Medicine Conference. That's the one in Orlando. And this is what's really cool for you people in healthcare economics. It's November 13th through the 16th in Orlando, but it's at the Rosen Hotel. So anybody who knows anything about free market medical care or Dave Chase or, understanding knows the Rosen Hotels are one of those companies that have taken healthcare benefits to the nth degree. And I just read this statistic the other day. It was 24 years they've saved over $240 million. And they put it back into like education for their employees and all kind of stuff. So they're a fantastic example of what you can do with a well-designed healthcare plan that is extremely employee focused. So that's why I'm like, oh, we're at the Rosen Hotel. This is so cool. So that's in November. But I also want to mention the American Academy of Family Practice. So AFP, this is their inaugural lifestyle medicine conference. And we were so excited to hear about this. And I'm actually co-chairing it with two other co-chairs. And these are women that I just have so much fun and respect with. So there's three of us that are co-chairing it, and it's in October. And it also is down in Florida. It's the place to go, but it's October 27th to the 29th. And so you would just look under AAFP Lifestyle Live. That's probably the best way to Google it. Because it's they consider the AFP Live Lifestyle Medicine Conference. That's the way I've been able to get to it. But that one, so the ACLM is like the conference. That's the big conference. You have people there, all the gurus are there, and you're going really deep into a lot of specifics. The one that is being put on by AFP, we're really going to we're having a lot of fun with it. We're taking all of these concepts of lifestyle medicine and teaching people how to, within 2.5, 3 days, to infuse them into your practice now. So helping people learn and understand what the concepts are. And then right away, we've got these personas. We actually have patient cases, and we're infusing this is how you would bring all of this lifestyle medicine into these real life patient cases. And we build on that for 2 days with the 6 pillars. And then at the end, we have participants, actually, hopefully I'm not any surprises, but then we have them present the patients. This is how they would then do it. So you'll feel confident being able to take a lot of this stuff back in. Now, I'm a huge fan of getting certified. So I'm actually board certified in lifestyle medicine, and that has a lot of meaning for me. And I think it's going through the education and the testing. It's not really all that hard, but it does take some focus to get into and to become board certified. But that's kind of the way these conferences set you up for that. So if people are all interested in understanding more, these would be 2 conferences. I'm like, just go, it's worth it. It's just, you're around a lot of really good people. And then hopefully you'll come out like I did from DPC, just charged, like, oh my gosh. And it sets you on that path to help you if you decide you want to become certified, which is, again, it's really nice I feel very comfortable. To you and I, being a physician it's a profession, and it really means something. And when people come and say they trust me, that means a lot to us. So for us, we're constant learners, and we really feel like this is important. So I really wanted to know, I understand the science behind all lifestyle medicine. I understand why it's evidence-based. I can really talk very deeply to anyone who's interested in that, but I also can translate it on a very simple level to help people engage very easily into helping themselves change their lives. So yeah, obviously I'm excited about the prospects of people becoming certified, but even if you went through like the AFP course or the other course, you would be able to walk away with stuff that you could then go back Monday morning and practice.
I love it. And especially being in the depths of DPC, especially if you're early on and you're working on everyday workflows for, what happens when a person calls into your clinic or what happens when the billing doesn't go through, and to have actionable steps that make, that lower the barriers to integrating family lifestyle medicine, I think is really awesome. So in closing, I want to ask, for the people who are listening, at no matter what stage of DPC they are, what are some words of wisdom that you would like to share with the audience as a take-home message to think about going forward into the future?
Wow. I think the biggest thing when people come to me, and I get a lot of people that are like, hey, I'm thinking about this. I'm like, do it. If you're thinking about it, you're suffering, there's a reason. Take the steps. And again, the timing might be different because I've got a lot of people are like, I'm ready to do it in 2 years. I'm like, fantastic. This is what I did before I opened. This is where I started. So wherever you are in this thought process, find good information. Again, so looking at this podcast, looking at some of the resources that you've been able to put out there because of the people that you've interviewed, engage, lean in, learn from all of those who've done it before. Everybody's a little bit different, so you'll pick up different things from those, from different people. Be realistic, be very realistic and understand why you're doing it and what you can do, and hire somebody the things that you can't. So a lot of the physicians that I talk to, they're excited about that, but like they don't want to run the business. They don't want to learn QuickBooks. They don't want to get a payroll. And so I'm like, okay, then you're putting your business plan how you're going to support a business partner. And that business partner is going to run the business, but you still need to understand what's going on. And that's okay. That's perfectly fine. Or like we talked about, are you going to do it solo? Are you going to do it with a partner? We've been able to grow, and I work with a lot of employers. So we've created a network called Try DPC. And all we are is an overlying administrative layer so that we can contract with the employers and then take all those employees and spread them out to all the docs. So helping them stabilize and grow with a great diversity in their practice. So they're not just relying on like one company or one area in the neighborhood. You've got all this infusion of all these different patients that can help stabilize practices. So find people in the area, and maybe you want to join a DPC that's already there. But do your due diligence so you can ask the right questions when you're thinking about joining another DPC, whether it's as a part owner or if somebody who you just, you want to be employed, but you understand the health, financial health of that DPC. So yeah, I guess it's just, the big thing is just take those steps, living life consistent with what your values are and consistent with your joys. Like I said, it's not easy, but it's simple, and you can make it easier by connecting with those around you who are doing it. Yeah, obviously we just want everybody to be happier and not suffering so much. The collective knowledge of physicians is so important, and we're losing these physicians. We're losing people because they're getting so frustrated and so crispy, and they're finding other ways of making a living with their medical degree. And I get it. But oh my goodness, we need your medical knowledge. We need your passion. We need everyone to lean in. I feel strongly the answers for healthcare are not in Washington, D.C. The answers for healthcare are not with one elected person, whoever that person might be, or board of people, or we have to work with the legislation. But the answers for healthcare are local, and they're with the people who really understand it like all of us, and we can lean in together.
I love it. And definitely leaning in, keeping it simple. I love how you summarized that earlier when you said, tag you're it. And that's how we continue to grow this movement. So Dr. Mechley, thank you so much for joining us today.
Mariel, thank you so much. Always a pleasure. And go get them. Team DPC.
Next week, look forward to hearing from Dr. Alia Hussein of Creekside Kids Pediatrics in Tomball, Texas. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.